National Hospital for granting us the platform. Thank you very much, Kenyatta National Hospital, for graciously agreeing the society to use this platform in their presentation. My name is Anne Wanyweke, a healthcare provider. I'm a nurse. I've been in healthcare for the last 17 years. Currently, I work at the Aga Khan University Hospital. I've had several positions and several posts. Most importantly for us this afternoon is I've been a quality advisor, quality implementer, all the way from implementing, initiating and implementing quality services. And currently I'm in operations. Joining us today is Society for Healthcare Kenya. And I will, in a short while, be introducing the speakers. This being our second session after introduction of healthcare quality improvement and how we can initiate quality in our various institutions. Today we are excited that we'll be talking on how we can actualize what we learned in our last session. As a society, providing exceptional patient care has always and will always be our mission. But ultimately, our success lies in our efforts, in our various capacities, all the way from the counties to the National Referral Hospital. Our efforts to continuously improve patient care through our innovations, changes in processes or modification, and adapting from new learning and new thinking. You'll all agree with me that now we are in a digital era. Artificial intelligence is now here with us. Technology has become an order of the day. And how well can we integrate these in improving quality and patient care? And therefore, as a society, our ability to deliver high quality care goes beyond new technology or research, but principally how we apply the principles of quality improvement is critical elements in ensuring safety, efficiency, and effective and patient-centered care in all facilities across the country. That's why we are very, very passionate this afternoon. So in this webinar, we will introduce and remind ourselves of the fundamental principles of quality improvement and how well this is being applied in service delivery settings. It is our second series, just like I have said, of our monthly webinars. So we have 3 more webinars until the year ends, and we will be collaborating with the Kenyatta National Hospital and the University of Nairobi to give out this talk and to share ideas, to learn from one another, how well are we doing in our various health settings. So joining us this afternoon, our first speaker will be Mr. Peter Mtanda. Peter Mtanda is a BSN holder and a master's degree holder. Peter is a healthcare quality improvement specialist and a trainer with experience in strategic management. He has a postgraduate training in healthcare management from the Strathmore University. He also holds a health administration degree from the University of Atlanta. And Peter has had numerous technical management and training, and that's why we are so happy to be joined by Peter this afternoon. He has been an active in healthcare services delivery, as well as healthcare management for the last 17 years. He's from starting and managing reproductive health clinics, maternal and newborn healthcare, as well as health programs in emergency and stable setting of family health options in Kenya. He has also worked with the International Rescue Committee and a university research company, and also he has worked with GPAGOL. Peter has also provided support for quality management systems at IRC and World Vision, and currently he works as a technical lead quality of care at the International Planned Parenthood Federation. Peter will be pouring himself out to us. We shall tap into his knowledge. He will be accompanied by Emily, who is our guest speaker, Emily Wamalwa, who is a quality improvement and a practicing registered nurse and midwife all the way from Kakamega. Welcome so much, Emily, and thank you for joining us this afternoon. Emily is in charge of the maternity unit at Navokolo Sub-County Hospital in Kakamega. She is passionate about the application of quality improvement approaches in the management of maternal and newborn care, processing for better outcomes. She will be presenting her case of her facility, and she will be sharing with us that in small ways, how is she improving quality care for the better outcome of our patients. So a bit of housekeeping as I welcome Peter and Emily. For all our questions, kindly drop them at question and answer. And for all our CPDs, the webinar organizers from the Kenyatta National Hospital will direct us to our various professional bodies. Once again, thank you so much for joining us. Please feel free to drop, to type in your question and answer. We shall answer them towards the end of this session. Thank you very much. Peter, you're all set. Welcome. Now the floor is yours. Come share with us this afternoon on quality improvements in healthcare. Karibu sana, Peter.
Thank you. Thank you so much. I hope you can hear me.
Yes, yes, you are audible enough, Peter. Take it on.
Thank you. So thank you for that elaborate presentation and introduction. So maybe I'll just switch off my camera so that we can allow better connection in many parts for those who are listening in. There you go. So thank you so much, and a very big welcome to everyone who has created time to join us for this second series of our monthly webinars as a Society for Quality Healthcare in the country. And today we'll be just building up on what was presented in July by Dr. Lydia Oktoi, who introduced us to the basic tenets of quality and why quality is important in our system. And we'll also look at, let's just see, is this moving? Yeah, so we'll want to maybe just remind ourselves, maybe we've gone through a quality improvement training or session before at your workplace as part of your training or in any encounters through the science of improvement work. I also understand these principles that guide us in QI, processes and measures. We'll also look at QI approaches and comparing the QI principles and approaches to other elements of management in healthcare that are in practice. And just like Anne has said, we'll get some lessons from the field, and that is from Kakamega. So maybe just to start us off, maybe by just way of just reflecting at individual level, let's just go back. Maybe the last time you had a healthcare encounter, maybe you had a routine checkup at your doctor's office, maybe you had emergency surgery, or you were just visiting a relative at the hospital. If you were to describe this encounter in not more than 2 words, what will that be? You know? What would you tell someone? Was it exceptional? Was it okay? Was it what you expected? Was it beyond expectation? And you see, many of us are full of praise of what works well. You know, maybe during the last visit at the local clinic, things went well. You were treated at the right time. You are given the right treatment. You are given the right advice or care. The follow-up was excellent according to your own perspective. But at the same time, we also know that we don't have some very good experiences, either at individual level, friends, relatives, people that we know that have gone through what was not the right care. You know, we've had stories of disrespect, delays in care, ineffective services, you know, misdiagnosis, or just very the abandonment of infrastructure in our healthcare system. So we hear a lot of experiences, and we also see a lot of harm being caused to our patients in many settings. And Lancet reminded us through this 2018 global report that if you are providing health services and you're not guaranteeing minimum level of quality, then you're providing ineffective care. It means you're wasteful, and also it borders on being unethical in your service delivery. So maybe a bit of history, and I know Dr. Lydia touched on this last time, a bit of history about quality. You know, quality is as old as mankind, and we cannot exactly say where quality improvement started. We can just maybe define how it has been sort of explained in the modern era. And then you see with every era of human development, it has always presented itself with very many developments, you know, even from prehistoric times to the modern age where we live in right now. The quality of life has always been increasing. You know, changes in human habitation, you know, changes in transport systems, you know, organized care, managing you know, emergencies, catastrophes like wars, diseases, you know, and just general advancement in the welfare of the human population. So when we look back at the history of quality improvement, you know, two names always pop up, and you know, we always hear about Dr. Shewhart or William Edwards Deming in the corridors of quality. You know, while Shewhart is really like the developer and creator of the, you know, SPC, statistical process control, and also was at the prime advancement of the, you know, plan do study circle. Deming took this to another level and just developed this whole profound theory that looked at you know, the psychology of human beings relating to their understanding of the knowledge of science, and also looking at how do we put that into the system to provide us with the right kind of approaches in service delivery. So, and again, many times when you talk about quality improvement, people always want to talk about Toyota or the industry or the manufacturing industry. And I think for me, we need to start really distancing ourselves from those learnings. We need to start creating our own learnings as a healthcare, you know. And that's why now you have the refiners who come late on, you know, people like, you know, Donna Bedian, who really structured how we think about, you know, structure, process, and how we put all these inputs through our system to give us better outcomes. We have the likes of Donald Berwick, who is always very instrumental right now. I think they're looking about equity and how that is important in quality improvement. So all these figures, and locally we have our own examples, we have our own champions who are refining and defining what quality improvement is for the modern population or for a country like Kenya. So healthcare has been improving. I mean, over the last 200 years, we've seen quite a lot of improvement, quite a lot of new thinking, quite a lot of innovations to better the quality of life. We have seen, you know, the internet, you know, the issues about big data analytics driving very big decisions in all corners of the world, including the healthcare sector. You're probably going through this training or this session using a gadget that was not even available the year you were born. So many of us have gone through probably medical training or sat through some training in a college as part of just learning the tenets of innovations and discoveries of medicine and healthcare. But I think documenting this, we have so many historical, you know, figures. You know, the basic hand washing, you know, from Semmelweis in the 19th century. You know, we know how penicillin has worked wonders through the accidental discovery by Fleming. We've seen all these efforts of organizing patient nursing care. You know, the Nightingale during the wars. We've seen better documentation of patient records as an important element of discovery, or just ensuring that we have cutting-edge management systems across the world. We've seen modern day senior physicians and surgeons like, you know, Dr. Peter Pronovost, who was really reached the level of patient safety advancement in various settings, just making the simplification of checklists to be quite an important element of service delivery to reduce, infections, post-surgery infections in many of our settings. So, however, we all also know that not all these discoveries have led to automatic translation to better patient outcomes. So the innovations are there, but there has to be a system that moves them from just the laboratory or ideation to actual practical outputs. And that's now where quality improvement comes in. So at the basic level of I'm assuming many of us are in the healthcare sector. You consider that you go through trainings, standards are available, we have evidence being churned out, scientific evidence. Every other time there's something new coming out. We have capacity strengthening efforts by the system. Healthcare workers are being trained, being given new innovations, new science. But we also know that these on their own are very good, but they're not sufficient. They're not enough to improve. They're not enough to go on their own. If you look at all from the Millennium Goals, right now we're talking about the SDGs, and in the last 2 years, all the conferences people are talking about, we are very slow in achieving our SDGs. We're just 7 years away from 2030. But where are we when we have all these good guidance, good guidelines? Because it means that there's something that we are not doing right. It's because it's not because we don't have the technical capacity or expertise, or we don't have the guidelines. It's because the system hasn't really decided to deliver the right care. And for you to deliver the right care, you must also be prepared to improve. So how do we go through improvement? Like I mentioned, there are many ways that things become better. We go to college, we learn new things. We develop ourselves as professionals. We get new things that we didn't know 2, 3, 5, 10 years ago through experiments, through research, through studies. Some things happen through trial and error. We've seen a lot of that in medicine and other healthcare sectors. We also have situations where, by coincidence, things have just become better. Something was being tried here, not in a deliberate way, but it improved. And that idea was picked and built into a system to make life better or to make a process much, much better. But when you talk about quality improvement, it has to be deliberate. It has to be based on an improvement science. It has to be based on ideas that are put into a structure, that are put into a system, to really guarantee that things are going to be better, to improve, and of course, ultimately, to make our clients and patients feel better. So maybe just to go through some common improvement approaches that we've seen before, or we've encountered in our own settings, or you've heard of. We hear a lot about the collaborative initiatives, mostly just situations where you group, communities or facilities in one similar sort of cluster and allow them to provide care in a more similar way, maybe tracking similar indicators. We have the Six Sigma, which is also used in Kenya, but mostly by private enterprise, but it borrows a lot more from the production industry. This just means that you are ensuring that every time you are producing 1 million processes, you only have maybe less than 4 of them having errors. That's a very high level of quality sustenance. We've seen, I think this was applied many years ago, where we are looking at how we use standards to recognize that things are getting better. And it was popularized mostly by the maternal newborn sector. But again, I think it was overtaken by a few other ideas that came later on. Benchmarking, we all know this. I mean, benchmarking, if used quite well, deliberately, it also gives you very, very good outputs in terms of learning. So we have the failure mode and defect analysis. All these have their own way of, maybe just learning more as a particular element. And this is where you're not going to wait for an error to occur. And I think during patient safety session, someone will talk about this more in great details. You are looking at being proactive, just looking at just processes. If we continue doing this in this way, these are likely that we are going to create a problem or to encounter a problem. So how do we fix it before it happens? We have the performance improvement approaches. These are mostly from the human resource world, rarely used in the public sector. But I've seen this also being applied in hospitals, private hospitals, major private hospitals, just like an appraisal of performance outputs at individual level. Then I think the other ones are more common, particularly in the family planning sector, the client-oriented provider efficiency, which was just look at time, waiting time for clients in family planning clinics. Quality assurance, this is a common one. Sometimes it's used interchangeably with quality improvement or quality control. Then we have the whole Deming plan, do, study, or circle that has also been applied in many circles of improvement. We have our own model in the country, which is the Kenya Quality Model for Improvement, which is not really a model, but it's a guidance, it's a conceptual guidance to quality improvement. So it gives us what we need to do in terms of structures. What do we need to have at facility level? What do we need to have at micro unit level? What do we need to have at sub-national county or sub-county level to guarantee better oversight on quality management or quality improvement? And then you have the work area improvement. We've seen about the Gemba Kaizen or workplace, just sorting a situation, sorting the work area to ensuring that there's order. And I mean, for those ones who know more about the Japanese way of doing things, it's just about making environment clean, making your place conducive. And that is usually really the beginning of quality improvement. Because if you cannot fix your work area environment, then it becomes difficult again to go to the technical aspect of improvement. The Donabedian model of structure plus outcome, I think we'll explain that a little bit more. Yeah, so these are mainly things that we hear and are defined in various settings. They come in different ways. And it also just depends on how they are applied, which model are you using, which approach are you applying, in what setting. Do you want to do just a quick management SWOT analysis, and you want to identify big time things to really fix, or you want to go now into the intricacies of identifying patient level areas for improvement? ISO, this is heard all over the world in all industries. And I think even the healthcare industry has borrowed a lot from here. KNH, ISO certified, this country, this county, this department, ISO certified. So it's just about assuring that you are living to your policies, you are living to your desires, to your mission. If you say that you need to have this kind of services, you're providing that service. So it's just about looking at yourself and ensuring that you provide what you promised to provide as an organization. So I think we can maybe try to understand quality improvement principles is that QI can only work in situations where there's a process that has been defined and there's a system that guarantees that that process will work. So improvement only becomes very useful and possible if the client is at the center of the discussion, if your patient is at the center of your discussion. And it's not about just what the provider knows. It's not about what the caregiver understands. It's not just about the new science. You invent a vaccine today, but you must also focus on what the patient needs. What are their preferences? So in quality improvement, always understand that patient is at the center of every word. In QI, you mostly are testing or measuring changes. There could be new ideas. There could be ideas that have been proven to work elsewhere, but you're just testing them in your system and try to see, do they apply here? If it worked in Kenyatta, can it work in MTRH? If it worked in Mombasa, can it work in Wajir? So mostly it's not about just putting ideas that have no basis, have no ground. It's not about discovering new things. It's ensuring that what has been applied elsewhere, what has been proven to work elsewhere, I'm putting it here and I'm learning through small tests of change and trying to see, is my context ready for this improvement? If it is ready, how do I scale that up? Again, another principle of quality improvement is shared learning. And this is very, very important because we see a lot of very nice improvements at a very small corner in a county, and you discover that this is only known by this facility or by this manager. No one else knows about this good initiative. So it's always good to share, because that's the only way that people will understand and also learn from you. So I like calling this the improvement anthem, that we work through systems, and the system that we work in give us the results that are supposed to be given to us. You know, the system cannot manufacture results for us. It's how it is designed. You know, if it's a good transport system, then it was designed to give you that good transport system. The system is not failing you. It's the design that has failed. So the system works perfectly. You know, and if there are chaos at CBD every evening, it's because we have designed those chaos. It's not because we can't, things just happened randomly. It's because deliberately we sat down and decided that at this time of the hour, this time of the day, there will be chaos in the city. So those are the results of your design. So it's not something else. So for you to change that, for you to improve that, you have to go back to the design. You have to go back to the system and ask yourself, what is it that is not working? What element of the process that I need to tweak to guarantee that the chaos become less or the chaos disappear? So again, for anything to improve, there has to be a deliberate focus, a deliberate aim, a deliberate idea that comes from mostly management to tell us that we need to change this for this to happen. So, and again, quality is already grounded in many of our global initiatives, many of our global documents. WHO talks about quality. If you look at the building blocks for you to ensure that you get better outcomes or good outcomes from these inputs, there has to be better coverage, there has to be better access, there has to be quality and also safety of our clients. So I mentioned about the Kenya Quality Model for Health, which is the national platform that guides our it's a bit old now, but I think maybe it's due for review. But this is it provides us the platform that it defines what we need to do at sector level for all the service provision elements, what is available, what can be structured. And many countries have gone ahead to have substantive quality improvement or quality coordination offices. And another thing that has been, we'll hear quite a lot from the next 3 months on how some of these counties have gone ahead to structure their systems. So what is high quality of care? It's a function of the entire system. Like I said, that the entire system has conspired to give you good results. The entire system has conspired to give you bad results. So again, addressing the client needs, the client being at the center. responding to what their needs are and in a respectful manner. I know respectful care has been some of the things that has really gained traction in the last 10 years, because just giving services disrespectfully is poor service delivery. And maybe just to define now exactly what is now quality improvement. When you talk about quality improvement, it does not stop. It has to be a continuous effort of everyone in the system, the professionals, caregivers, patients and their families, researchers, people who are paying for the service, the planners for the service. It has to be a combined effort to make the necessary changes that will give us better outcomes at patient level, and also better system performance, and also ensuring that we are always developed professionally as individuals and also as systems. So, in quality improvement, we talk of outcomes at individual level, because many times when we talk about quality improvement, we are targeting the central unit, which is the client or the patient. You can improve quality at the system level. But I think the basic tenet of ensuring that you have larger improvements will start when you look at individual patients. Are we providing them with dignified care, respectful care? Are they getting better experiences? And our system is efficient enough? Are we misusing our services? Are we underusing them? Are we not using them in the correct way? So that combination of these aspects will give you better patient outcomes at any given time. So I just want to borrow Juran, who is also, I didn't mention him earlier, but he's one of the gurus in quality management. And he split this into 3 areas. There's the quality planning, and then there's the quality control, where you have the control zone, and also improvement comes in between there. Then you have another defined way of doing things. So in the planning, you already know what is existing. You're operating at a level, between 18-30%, and that's how the system is designed. It only gives you that. Your county system is designed to give you probably 50 in 1,000, 50 deaths, natal deaths in 1,000 live births. Maybe it's designed to give you this level of incidence of malaria. That's how it is. You are trying something that's not working, but that is how it is. It's guaranteed that every other time it's just going to be between maybe 20 and 50 or 60 and 30. So you put that's now where you apply quality improvement, because you're developing a process that creates a different way of doing things, to optimize that moving from one level of delivery to a superior level of delivery. And that's now where the effort, that's how we apply the science that we are saying. We're not going to react to these sporadic things that give you very high bad performance, then you come in there and fix things one day, through a report management and say, we're not doing this, we didn't do well this month. No, you don't react to that particular one incident. You react to the entire duration of bad productivity. Then you inject new ways of doing things to guarantee you another level of performance. So when you're approaching quality improvement, you don't just look at one bad thing or one bad incident. We had a maternal mortality. Everyone is rushing. You do something, then again, 1 week later, there's another mortality, then everyone is rushing to do audit and everything. But are you looking at the system? Because it's guaranteeing you maternal mortalities every month. So what is the system? How is it designed that you're almost sure that without a month, I'll get a newborn death in my nursery, in my newborn unit, or I'll get this level of infections in my surgical unit. It's not like it's just spiked today. There have been warnings over time. So when you're doing QI, you look at those warnings. You don't look at an incident, you just look at historically what has been happening that will always, if we don't fix it, will guarantee that something wrong is again going to happen. So again, in terms of just going back to the building structure, looking at how the inputs apply, how you apply processes to the inputs to give you better outcomes. So that's a good way of looking at it. If you look at our Kenya model for quality management, KQMH, it also has these 10 elements, the structure. And if you look at them, 6 of them are just about the WHO building blocks. Then you have the process, and in between there, you have to work around continuous quality improvement to guarantee you better outcomes, client satisfaction, and not forgetting also the staff satisfaction, because it's very, very important also to look at providers when you're looking at quality improvement. So as I just come down to finish this, and many times we see this being used interchangeably, quality assurance, I'm a QA officer, or QC manager, or QI coordinator. But in terms of their use, it's just good to sort of differentiate what applies where, in many times quality assurance is just maintaining what has been defined already, the level of quality of this product or this service is at this level. So I'm going to check, are we maintaining it at this level where we had it initially? And many times you're just responding to what is already existing. In a similar way, quality control is mostly used for products, not mainly for services. But again, it's just you've reached out a control area. You've calibrated your service to some level of control. So anything up, anything below, you react to it. So it can be a control for, you can control a situation or a process, but we're not performing well, even if it's under control. So maybe you want to move from that particular control to another level of control, either higher or lower, depending on what you desire. But now in QA, it is being proactive. It's just constantly maintaining what you know is good, or going further to look at elements of the services, elements of the process. What can you initiate at any phase of service delivery? When do you want to improve your level of care? At what point? So it has to be continuously. You can never say that now you control your care at 5% infection rate. That's now enough. No, you always aspire to come lower, to maybe 4.5 or 4%. So that's why it's not always good to compare the control way of doing things in the industries with patient care, because you can control a machinery output for even 50 years and it still gives you good results. But you cannot say that you control your patient level care to this level and you want it to stay there for 50 years. You always aspire to do better every time. So maybe just to touch on quality improvement and relation to behavior is that when we talk about social behavior and when we are messaging around human factors, human behaviors on how we do things, our message should not be about we are doing this, you are washing your hands to prevent a disease. You're using good sanitation facilities to prevent this. You're doing 1, 2, 3, 4, getting a vaccine to manage this or prevent this kind of infection. It should be around, you're doing this to improve the quality of life. It's about the life cycle. So it's not just an event to reduce diarrhea. It's about I'm doing this to improve the quality of life, to become better. So the community will understand that this is not just because being safe. It's about making sure that things are okay. And when you looked at what happened during COVID, a lot of things that are being really high impact things or interventions were not about waiting for the vaccine. It was just about how do we behave to prevent the risk of infection or the spread of COVID. It's just about our own behaviors. How do we assure that even as we are waiting for the treatment to come, we're already ahead of the game. So it's all about behavior. And QI is not always about new drugs, new discoveries, new ways of doing things. You know, quality drugs, quality medical devices will prevent ailment, will prevent morbidity, but how do we deliver those services? How do we ensure that what has been discovered goes to the last mile? And that's what prevents mortality. You know, we have enough antibiotics, but we still have people die of infections. We have enough devices, but we still have people who cannot access surgery. It's not about the quality of the drug. It's not about the quality of the medical device. It's about how do we improve the service delivery to prevent more harm in our system. So I borrowed this from two senior OBGYNs and researchers from the UK, and they have documented this. It's a very old paper, I think 2015, and they were looking at mortalities or deaths from maternal hemorrhage in the UK. And this is very, very old information, more than 150 years of tracking this kind of information, and you realize that even way back, by the time things like augmenting are being discovered, things like modern, midwifery in the 1901, just designing what midwifery was all about, there were some things that were already going on. People didn't wait for augmenting to manage, post childbirth bleeding. People didn't wait for syntocinon, which was coming in maybe around maybe in the 1950s, somewhere there. Already there was improvement. So it's not about waiting for the new innovation. It's about what do you have in the system right now to guarantee. For those in the RH sector, the active management of third stage of labor, it's not something that was there in the 70s. I think it was just around in the 80s when we really defined active management of third stage of labor. But at the same time, many countries were already really seeing quite big drop in management of PPH. The other example, I think many of the public health students here will have seen this in their classes or in their trainings. The Americans didn't wait for polio vaccine or penicillin in 1930s or vaccine polio, which came in the 50s, to reduce their crude mortality rate. So basic things were already going on, improving sanitation, safe water, improving the whole, habitation, quality of life. And you can see there was already a drop even before big innovations like vaccinations came in play. So I think I wind up here and just maybe speak about a few lessons. So when you're doing quality improvement, you do not want to focus on calling yourself excellent or focusing on the ultimate excellence. It's always about learning. Even if you went to the top hospitals in the world, there's always something that they're learning. There's always something that they're trying to improve. It could be even just how they deliver food to their clients, how the time it takes to do a diagnostic. Maybe they just want to reduce that by a minute, or by an hour or a day. So always focus on learning and improving. Don't focus on excellence. And then it can be confusing sometimes out there. People come, especially non-state actors, they'll come with many concepts, defined in different ways, calling them this and that approach, this and that idea, this and that concept. But the model is the same. You're identifying a problem, analyzing a problem, you're developing changes, planning around those changes, testing the changes, studying them, and acting upon what you're studying. So let's not always be confused by so many of this jargon around quality improvement. Just go with the basic, go with the concept, not the model, every time you are trying to improve. So in QI, again, many people, you want to avoid a lot of things that are routines, what has been done before, people are not doing this. People are not doing this procedure well. Let's train them. The people jump to trainings very fast. Let's put up an IC material. Let's have a CME in the morning. People are coming late to work. As a management, you say, okay, let's introduce a clocking register. It's not about introduction of all these initiatives. It's just about how do you look at the human behavior. Why are they not doing that? Very important. Because for you to improve something, human beings must be with you. So you must understand the psychology, the human factors that relate to quality improvement. I talk about RRI very much, the Rapid Result Initiative, and a lot of the RRIs that we do, especially in this country, are quite wasteful, really. Very, very wasteful. So people wait for, 52 weeks of the year, then you wait for 2 weeks of December, and then you want to do an RRI to improve HIV testing. First, you're going to waste people's time, you're going to destabilize the system, so the whole commodity management sector will be rushing around to manage your 2 weeks. While if you put in a QI initiative from January, you will not need that RRI. So RRI have, in fact, right now they have become part of our healthcare system. We wait to do an RRI. We even plan for RRIs in our planning. So let us introduce quality improvement in step by step, small steps. You know that this is a gap. Where do I start from now? Not waiting the last 2 months of the year. Then everyone is running around doing this, kick this out, kick this campaign out, and all those things. The other lesson is, I think I talked about training. So the training and supervision, telling people to work hard to improve on their own. The system is not changing, will not guarantee you. So it has to be changes within the system. Improvement is about changing. It's about changes. Nothing improves without changes. Again, it's all about leadership in QI. If you have the right leadership, things get better. If it's not about new interventions, not about new science is always good, it's always welcome, but you can still improve with what you have every time. And improvement is not fast. It's not easy. I just remember this some 7-8 years ago in a particular facility, and they were saying like there were so many sepsis or infections at the newborn unit, and they were like, okay, we cannot afford this. What can we do? And you'll imagine that all these changes are very basic stuff, IPC protocols, patient education on handling newborn. And you think about them, you see, okay, I think we can fix this within 2 weeks. No, it's not that easy. It can take you up to 12 weeks just to change a simple thing that you feel is common for things to get better. So for QI to be sustained, you have to put a structure in place. You don't just say, okay, tomorrow morning, everyone must come. You must be washing your hands. You must be using the right equipment. It's about digging down. What are the root causes? What is that is making us behave or perform at this level? And what are we going to do as a change package to ensure that we are better? Then in quality improvement, don't go too far. Don't go too much outside what is not known. Because sometimes let's think outside the box. Sometimes just within that box. It's within that unit. It's within that team that you left at the service area and you're in a management committee. That team that you left down there may be having the answers to your improvement. So always involve everyone. Think with the people, think with the workforce for you to get better ideas. I think this should be one of the last ones. So improvements, we measure a lot. In QI, we don't measure data just because we want to know, because we want to know how it is behaving. We measure to improve. So if you are measuring for improvement, ensure that you have an improvement plan in place. So don't just collect data. I mean, unless you are doing research, you don't just measure for the sake of measuring. Say we want to measure this, and at this point, we want to see how it is performing, how it is behaving. Now, at this point, we want to implement these changes to give us these outcomes according to our theory. Then you implement. So you'll find people really collecting a lot of information for a whole year. Then you're collecting 6 indicators or 10 indicators, are only improving 1. Then you start wondering, why are you collecting all this information? You're wasting people's time. They become lethargic, they lose the energy. It's because what you're collecting is not being used. So when you want to improve an element of a process, collect what you want to improve at that particular moment. It gives the workforce a little bit of motivation. Then share. I repeat, share and share and share. It's pointless that you are doing well as a county hospital when your sub-county hospitals are struggling with the same process. So why can't you just share with them so that you can, you can improve together as a team, as a unit. So and I think that is the last slide. And maybe just to summarize that quality is for everyone. There are many trainings out there that you can dig yourself in deeper to understand the science, the concepts. We all know that right now it's not just about access. We've been told in the last 5 years, if we improve our quality, even without increasing access in many of our health indicators, things will really, really be better. Then quality improvement, of course, has profound benefits to increase access to better healthcare every time. Thank you very much. Back to you, Anne.
Thank you so much, Peter, for that very insightful presentation. Indeed, there's a lot to learn. Now we turn to Emily so that we can have a session for Q&A. Emily, you're welcome to present to us what you're doing in Kakamega. So that Peter will be back with Emily for our Q&A. Emily, are you set? Yeah, Emily, you're most welcome.
Good afternoon.
Good afternoon, Emily. Yes, we can hear you.
Yeah, Emily Wamalo is a nurse working at Navakholo Sub-County Hospital, Kakamega County, a service provider. So I would like to take you through our QI project that we are working on. Our QI problem is low uptake of postpartum family planning within 48 hours in maternity at Navakholo Sub-County Hospital. Our aim is to improve on the uptake of postpartum family planning within 48 hours in maternity at the facility from 8% to 50% in 6 months. That is, we started in 1st March 2023. We shall be ending it at 31st August 2023. Then our QI process is active. QI improvement approaches. Our problem factor, our factor remains low uptake of postpartum family planning within 48 hours in maternity using long-acting reversible contraceptives. We have several root causes with their change ideas. Our first root cause is lack of provider postpartum family planning knowledge, competence, and attitude. The change idea of the countermeasure being OJT, peer-to-peer skills transfer, trainings on postpartum family planning, and regular supportive supervision. Our second root cause is lack of dedicated or designated person to provide postpartum family planning. The countermeasure being all midwives are to prioritize postpartum family planning as part of their postpartum care. Then we have lack of knowledge and poor attitudes by clients. The change idea being a provision of health education in MCH early counseling on method choice in the ANC antenatal clinic, and we are using the CHVs and the TBAs as our village counselors. Our fourth root cause is gender dynamics. The change idea being we are involving male and postpartum family planning services, and we're also having community dialogues. Then our last root cause is inadequate and incomplete sets. There we have to source or procure insertion and removal sets. On our PDSM, PIM, two change ideas with highest impact were selected to be tested. One of them being there we pair experienced midwives on postpartum family planning with those with limited knowledge for OJT and peer-to-peer skills transfer. Secondly, the midwives are to prioritize family planning as part of postpartum care and do counseling so that mothers make their informed choices or how are we doing it. Here, we have to identified the midwives to offer OJT or mentorship, then identify the midwives to receive the peer-to-peer skills transfer, do a weekly tracking of midwives who have received peer-to-peer skills transfer, and lastly, track the number of women who have been counseled on FP and those who have received postpartum FP within 48 hours. Next slide. Our study, the tests were carried out as it was planned. Then the change ideas are feasible, and with full implementation, we will improve the uptake of postpartum family planning. The change ideas were feasible, those were all adopted.
I don't know why it's not moving.
Our results. So far, 5 out of 5 of our midwives who needed OJT have all been mentored. Then in March, 115 out of 141 mothers were counseled on PPFP. Then out of those, 24 mothers received FP methods of their choice. In April, 120 out of 134 postnatal mothers were counseled on family planning. 61 made informed choices, and they all received methods of their choices. Then in May, 102 out of 165 mothers were counseled on postpartum family planning, and 43 mothers made informed choices, and they all received methods of their choices. Then in June, 107 out of 123 mothers were counseled on postpartum family planning, and 49 mothers received methods of their choice. Here, let's appreciate our presentation, the findings. Our absolute figures are tabulated in a graphical form. January and February, there are baselines. In March, we started OJT and peer-to-peer skills transfer. There we were at 63. In April, all staffs in maternity were mentored. After mentorship, we can see there the number of postnatal clients who received PPFP increased to 45. In May we were at 26. There was a drop. We had challenges with the commodities. Some commodities were out of stock. Then in June, we were at 40. The lesson learned, one, minimal resources are needed to carry out peer-to-peer skills transfer. Then designation of nurses or midwives on duty for PPFP had an impact on counseling and PPFP uptake. With our own observations, group counseling has low yield of mothers taking up PPFP as compared to one-on-one counseling. Then high workload and commodity stockouts also impacted negatively on the uptake of PPFP. Our recommendations. Our staffs on duty are to offer postpartum family planning to mothers before discharge in maternity. Then we have orientation and mentorship package for 1 week to all staffs who are deployed in maternity. Because we are equipped, we have slides on FP. We also have equipment. So we won't have any challenge in mentorship. Then our CQI is ending in August, at the end of this month, but we shall continue with the process until postpartum family planning becomes a routine service at Navakholo Sub-County Hospital. Thank you.
Thank you so much, Emily, for sharing with us what you're doing on the ground. That was really, really insightful. And you've actually modeled what Peter had previously presented to us on how well we can implement quality initiative projects in our various settings. And we can see from your presentation that you did identify what you needed to do. You analyzed your situation, you developed your model for presentation, and you implemented a plan, you've acted on it, and we can see the results. You've actually tested and implemented that which you identified. We really, really appreciate you and your team at Navakholo in Kakamega. Well done, nurses and midwives from Kakamega. Thank you very much. Now it is that time of questions. We will be taking your questions. We had kindly requested that if you can type your questions in a Q&A platform. You can also raise your hand. Our able IT team will unmute you and we can hear you out. I see so many of us asking about CPD point. I had already assured all of us that through the webinar organizers, you will be sent your CPD points in your various professional bodies. Those of from Nursing Council, from is it KPDU? Yeah, you will all get your PowerPoint. Yeah. So Emily, there's a question for you. Someone is asking, Emily, is this purely a county initiative or there are other partners on board? Emily, you can unmute and respond to that. Someone is asking, is this purely a county initiative or there are other partners on board? Emily, can you hear us? Yes,
yeah, I'm getting you. Yeah, we have a partner on board, that is a UBJ with our county government.
Probably you can
Hello?
expound a little bit on your partnership and how well you have partnered with them in implementing this, so that others can learn how they can look for partners and collaborate in implementing quality initiatives in their various settings.
First of all, we were trained on KQMH by the county in cooperation with our partner UBJ. Then from that training, we have champions. We were also trained. And from there, we're also having mentorship and monthly meetings.
Thank you very much. Awol, I hope your question has been answered. I see several hands up. Nelson, you can kindly unmute Anzala. Anzala, your hand is up. Others, you can feel free kindly to
Hello, this is Anzala. Can you hear me?
Yes, Anzala, we can hear you. Please proceed with the question.
Yes, thanks. This is great, the presentations that were done by our two speakers. For those who have not heard, I'm from the University of Nairobi at Kavi Institute of Clinical Research. For us, really, the whole issue of quality is at the heart of actually everything we do. And training, as was indicated, is continuous. And there were two things that I've learned over the years that I would really like to push through when we talk about quality and ensuring that we have quality healthcare. One of them, and what I've actually seen, is attitude. Healthcare, workforce attitude. And I'd like our two speakers to mention that training is one thing. We are being trained all the time, WHO training, CD4, CDC training, we are all being trained all the time. But you go to our healthcare places and it is just horrible. So how do we ensure that once we have trained, there's a good attitude? Because what is actually killing us, from what I've seen over time, Peter and the other, was it Emily who presented, is attitude. Now,
Peter and Emily, you want to take up
you
a
have
question?
actually worked on the attitude.
Peter,
This excellence is actually sustained, because that's what is another problem. And then number three, how do we deal with the fresh, new incoming healthcare provisions to various services? How do we induct them to this good provision in ensuring?
Very well noted, Anzala. Peter, you can take these questions from Anzala.
Yes, I'll try. Do I take this one or there's another one? Maybe you combine.
You can respond to this first.
Okay. Thank you very much, Professor Anzala, and I'm really happy that you listened through our presentation. So I agree with you.
I dropped off. Yeah, sorry, I dropped off, but those are the comments I wanted to.
Okay. Thank you so much, Professor, and we appreciate your inputs and also your perspectives around the attitude of the providers in our healthcare service system. So when you talk about QI, one of the elements that we always forget about or don't consider when we are just providing services, leave alone improvement, is the human factors. And I know Dr. Oktoy mentioned part of this, and I think this will be mentioned a lot when we talk about patient safety, is that we rush to improve and put in initiatives like training without considering what are these other underlying aspects of service delivery that are hindering optimal care. So you will find suboptimal services being provided in a particular setting, and then people assume that people have not been trained, people need to be refreshed, and people sometimes go for training, either just to as a way of maybe freshening up, not in the knowledge, but maybe just being away from the service. And in many times, we do not have other elements being factored in even before the training. And that's why anytime you want to improve services, I think we need to sit at the table and involve, like I said, you have to involve the providers. Do they really need actually the training? Is it something more? Is it a management situation that is not allowing them to provide the right care? And I saw situations where it all went down to just even the attitude of management to the providers, and just improved. And it's just being candid with our approach to service delivery, not just the technical competencies or to understanding of the whole, clinical aspect of care, but what are these other things that make people not provide the right care? I don't believe any doctor or any nurse wakes up in the morning, puts on a very nice attire suit and goes to the workplace to do wrong things. So it's a multiplication of many other factors that will lead to that person not having the right attitude towards care, not delivering what is desired, even with the availability of resources. I think it's just the function of management to look at what are these other human factors that are hindering our approach to better service delivery beyond just the technical know-how. So if you look at the Deming's approach, it's the psychology of the human behavior, is the knowledge of what we know. We know this works. We have evidence. It's again the system that will combine. All these things are going to combine to give you what you need. So even if you are training and you are training, you're supervising people, you have all these checklists, but there are some things that are not being taken care of, then that becomes a problem. So QI sits at management. QI is implemented by the workforce, but it sits at management. If you do not have the right leadership, you don't have the right chaperone for initiatives, then things tend to become very micro, very minute, and many times, they just die off at unit level. So who is this leader who will champion this improvement? Who will look at beyond the technical expertise? What do people require here? The people working in theater, they have time for meals? Do they have enough workforce? Do you compensate for people's time spent? Do you look at areas where people may be having some issues, social situations that may be also affecting their service delivery? So that function is vested at management. And I think from my experience, it is, when you talk about attitude, it's very easy to push it to the workforce, but also as management, we need to look at what is this? What is this that is creating this barrier to optimal care, while we have given people all these gadgets, all these guidelines, all these trainings. Yeah. I had an example of a nutrition process in one of the countries, and they had everything, but it took them 7 months just to improve the process. And it was all because of attitude, and that was just a management situation. Yeah. So those are my thoughts. Back to you, Anne.
Thank you, Peter, for chiming in on that so well. I don't know whether Emily has something to add, but I would also like to add that it is important for every organization that when you're implementing a quality improvement project, it it's important to recognize that every organizational member will require connection during the implementation, from inception actually of this idea. How well are the members involved? How well do they feel connected and parts of the quality improvements to be implemented? Is their voice in this? Because that really will determine their buy-in. And then the organization or the facility needs some counsel advice. We say that a part of the quality, one of the contributing factors of a successful implementation of a quality project is the learning. We've done it as a organization A. Organization B is about to implement it. What lessons can you learn? You don't really have to go through the entire circle, but you can learn from those who've gone before you and try and evade those bottlenecks and hurdles along the way as you implement. And as we go along, I've been part of quality improvements in various places. How we correct the process really matters. How we give in our input during the implementation will really matter. Peter said, we don't need to measure everything. We need to see the results, but how do we measure them? The how really matters. And we need compassion to the implementers of this quality improvement, because the organization, and that is at leadership and governance, they are so hard on the people on the ground who are implementing this, without obviously getting to know where are the challenges. They are so interested to see the results, but the process, which can be so excruciating, it can be painful, it can be difficult. That's why these people will need compassion. And that's been also to another comment on how well are we modeling, or how well are we passing the batons to the new people who are coming on board. I think for me, the best thing is how we do it, because they will see how we are doing it and they will do the same. So in as much as we teach theory, is the theory practical? We've just seen Emily doing a small thing in Kakamega. That thing can model the entire country on how well we implement the family planning postpartum. And I think the best way as healthcare providers is how well we model these things. Yes, Emily, do you have something to chime on this? Emily, there's also a question for you. Yeah. Someone was asking, what are the risks of family planning? You could answer together with that.
Yeah, hello.
Yes, we can hear you.
Before we offer Before we offer any family planning to our clients, we have the eligibility criteria that we usually follow. And so far, or from, we usually Before we offer any family planning to our clients, we usually use the eligibility criteria. And so far, we've not had or received any reports from our clients on any life-threatening issues or risks.
Thank you, Emily. Peter, we have another question for you here. And Joseph is asking, QI, what are you trying to improve? How will you know if there is change, and what changes will result in improvement? Yeah, that's the only question I can see in the chat. Oh, yes, there's another one also, Peter. Someone is also asking, how do you deal with turnovers for private hospitals? Gains are lost and trainings are expensive.
Yeah, I think the second question is maybe outside my remit, but again, when we focus on training without looking at other elements of service delivery, we will not receive much output, because the training on its own does not guarantee that care will improve. But the other aspect where someone is asking about ideas, when you talk about improvement ideas, sometimes we struggle to look for new ideas. QI is not about new ways of doing things all the time. It's about new approaches to doing things in a known way. So we don't create new science. We know what works. If we don't know what works, then you're testing a theory. We're testing a theory, and that has to be in a controlled environment. So many times we have packages of intervention that have already been defined for a particular process of care. So it's just about this package of intervention or elements of interventions. How do we apply them in our system, and how do we deliver care? So it's the science of delivery of care. It's not the science of discovery. So all these changes, many of them are known things. They worked elsewhere, but they may not work in your system. That's why you're testing that idea. Not because it's a new idea, but it's new to your system. You are applying it in a new way. You're applying it in a different way, and you're testing it to see, does it work in my context if I applied it this way? So people sit on QI planning tables and they're looking for all these new things, new discoveries. No. It's about what has worked elsewhere. How do we define that and apply it in our context and push and measure that? Because you're measuring a process. You're not measuring if this intervention works, because that's beyond quality improvement. For you to measure what works, now that is in the sphere of working at Professor Anzala, testing ideas through research, or innovations through research, or new science through research. But QI focus on what is already in the box. I talked about focusing on what is known, and a lot is known, and a lot that is known is always good enough. It's just about how we approach and how we deliver it. Back to you, Anne.
Yeah, thank you very much. One more question for you, Peter. Yeah, there's a comment and a question, and someone would like to hear from you. They say, quality costs. There is a price to quality, but no quality is more expensive. Please comment on actions being taken to urge institutions to invest in quality. And I guess also we have Peter Mulongo on board. Peter is also one of us from Society for Quality Health Kenya, where Mike, you can also give a comment on this. How are we convincing, or what are we doing to urge institutions to invest in quality?
Dr. Mike, are you going with that, or
You can give your comment, Peter.
Okay.
Mike will add, yeah.
Okay, fine. So you are right. We have to invest. But the biggest investment is about structures. The biggest investment is about oversight systems and structures in organizations. Either it's that surgery unit or mat unit or pediatric unit. Where is oversight for quality? Do people understand the science of improvement? So that is usually the biggest investment that you want to apply. So quality becomes expensive if you're introducing completely new innovations. You are scaling up very novel ideas to maybe to a larger population or to scale. But investing in quality of care is not expensive. We've seen from data from 2018, the Lancet report told us that access to care is even more expensive in terms of outcomes than quality of care. So if we put more efforts in improving the quality of what we are providing right now, we are guaranteed better outcomes. So even if we stopped, investing new things today for a year and say we want to improve what we already have by 50%. Then we are guaranteed that we'll have better patient outcomes, better improvements. So when you talk about investment in quality, for me, it's just about what are the structures that are existing in an organization? Do they have an oversight for? Do they have an improvement? Because many countries that are way ahead, this is where they started. They always had quality improvement unit, departments, but everything has now been infused into a culture, into a practice that when I leave college, I know I need to do this 1, 2, 3, 4, 5, and this is the process. So I don't need to be reminded to do 1, 2, 3, 4, because it becomes like a behavior. But I think the behavior is still lacking in terms of adherence to what we need to be doing. So, and I repeat myself here, it's not about new science, it's about new ways of doing it or inputting what has worked elsewhere in our context to make it work. Back to you, Anne.
Thank you very much. I don't know whether Dr. Mike will give a comment on that. I see there's one more question for Emily. Emily, get ready. Is it a must to force a client to get the family planning, or it's optional? Emily?
We are not forcing our clients, it's optional. We only give or provide health education on the available family planning methods, and the client they usually make the informed choices. We don't coerce.
Thank you. I note all the comments in the chat. Someone say yes, culture change, and I see now, Mike, your hand is up. A culture change survey done in level 4 facility illustrated how toxic spaces is a trickle-down effect of leadership / management deficit. Therefore, management is the gatekeeper to quality of care. And yes, we agree, management needs to be fully involved. And someone reassure us that there is implementation of Kenya, that Kenya is implementing KQMH countrywide. We do appreciate that. Yes, Mike, you can give your comment. Mike, Dr. Mike, are you able to talk? Probably he's not able to talk. And yes, there's also another comment. Someone says, as a sector, we also need to root for an independent body to champion accreditation, inspection, and issue certification. Yeah, and also would like to acknowledge that all your CPD comments have been taken into, and that will be channeled by our webinar organizers at the KNH. We are drawing to the end of the hour, to the top of the hour. I would like to take this opportunity to thank you all for joining us this afternoon. And a big thank you to Peter and Peter from the Society for Healthcare Kenya. Thank you so much, Peter, for that very insightful presentation. You broke it down in a way that everybody everywhere can really walk away with something that really we do not have to reinvent or invent a new wheel. Something is already happening. We can only look for better ways to improve that. And you gave us a whole lineup of several approaches how we can implement quality in our various institutions. We just need to understand the key principles on how well we can implement these. And Emily, you have demonstrated that all the way from Kakamega, that we can do small things differently and get better results and reach out to improve our healthcare outcomes. Thank you very much. So without further ado, I would like to once again to thank you, all of you, and I appreciate the virtue clapping for our speakers. Thank you. Please also clap for the KNH and the University of Nairobi for granting us this virtual platform. We will be back every first Wednesday of the month. The Society for Healthcare Quality Kenya, we get this platform. Again, we will bring other people from various counties to see how well they are implementing quality in small ways to try and reduce morbidity and mortalities in our healthcare. And yes, we hear your comments about the accreditations, and I would like to assure all of you that this is work in progress, and that's why we have this platform. You can join the platform. The society is open for all healthcare providers. We do share this information in our website and also in our WhatsApp platforms, and we have participants cutting across the county. Thank you very much, and we will meet you next month for another session on how well we can implement quality and, of course, learn from other counties the good work they are doing. We appreciate you all. Thank you.
Thank you, everyone. Bye.